Let me ask you something very direct. Have you been feeling more tired than you used to? Maybe your ankles are a little swollen at the end of the day. Maybe you've been waking up at night to use the bathroom more often, or you've noticed your memory isn't as sharp as it was a few years ago. And when you brought it up with your doctor, they looked at you, nodded, and said something like, "Well, that's just part of getting older." But here's what they didn't tell you. You started one of these medications, Amlodipine, Losartan, or Lisinopril, and somewhere along the way, your body started changing. And the medical system, as well-intentioned as it may be, has a habit of blending those changes into the background noise of aging. They call it aging. They call it stress. They call it normal. But what if it isn't? What if what you are experiencing right now is a direct, pharmacological, documented side effect of the pill you are taking every single day to protect your heart? That is exactly what we are going to talk about today. And I want you to stay with me through every single word of this, because this is not a video about stopping your medication. Please hear me say that clearly. These medications save lives. High blood pressure is a silent killer, and the drugs designed to treat it are among the most prescribed and genuinely necessary medications in the world. This is a video about informed consent, about the right every patient has to understand what is happening inside their body, about the gap between what doctors tell patients in a 10-minute appointment and what the research actually shows. Because those 6 side effects, the ones we are about to walk through together, they are real, they are documented, they affect millions of people, and far too often, they are dismissed. Amlodipine is a calcium channel blocker. Losartan is an angiotensin receptor blocker, what doctors call an ARB. Lisinopril is an ACE inhibitor. 3 different drug classes, 3 different mechanisms, but what they share is a common mission: to lower your blood pressure, and a set of consequences that overlap in ways that are rarely explained to patients when they walk out of that office with a prescription in their hand. Let's start with the first silent side effect, and it is probably the one most universally waved away: fatigue. Not just tiredness, not the kind of tiredness that a good night's sleep fixes. We are talking about a deep, heavy, dragging exhaustion that settles into your bones and doesn't lift. The kind where you wake up after 8 hours and feel like you haven't slept at all. The kind where climbing a flight of stairs feels like an achievement. The kind where you used to be sharp and energetic in the mornings, and now you need an hour just to feel like a human being. When patients report this to their doctors, and they do, constantly, the response is almost always the same. You are getting older. Your metabolism is slowing down. Maybe you need to sleep better. Maybe you're stressed. But here is what the clinical literature shows. Amlodipine, by blocking calcium channels, slows the movement of calcium into the smooth muscle cells of your blood vessels and your heart. That is how it lowers your blood pressure. But calcium is also essential for cellular energy production. When calcium signaling is blunted systemically, it doesn't just affect your arteries. It can affect your mitochondrial function. The energy factories inside your cells work less efficiently. And the result, for a meaningful percentage of patients, is that bone-deep fatigue that no amount of coffee touches. Lisinopril and Losartan operate through the renin-angiotensin-aldosterone system. This is a hormonal cascade that regulates not just blood pressure, but fluid balance, electrolyte levels, and cellular communication throughout the body. When you suppress this system, you lower blood pressure beautifully, but you also alter how the kidneys handle potassium and sodium, how blood flow is distributed to muscles during activity, and how efficiently oxygen gets delivered to your tissues. The fatigue from ACE inhibitors and ARBs is well documented in clinical trial adverse event profiles. It appears in the fine print, but the fine print rarely makes it to the patient. The second silent side effect is one that is almost universally attributed to age by physicians, and it is arguably the most emotionally devastating one on this list. Cognitive decline, brain fog, memory lapses, that feeling of standing in a room and having absolutely no idea why you went in there, forgetting words mid-sentence, losing your train of thought, feeling like there is a layer of gauze between you and your ability to think clearly. This one is deeply personal for so many people because when your memory starts to slip, the fear that follows is enormous. People immediately think about dementia. They think about Alzheimer's. They catastrophize, understandably. And the doctor says, This is age-related cognitive change, completely normal. Don't worry. But what if your medication is contributing? There is a growing body of research, and I want to be careful here to represent it accurately. That raises serious questions about the central nervous system effects of long-term antihypertensive use, particularly in older adults. Amlodipine crosses the blood-brain barrier. Calcium channels are critically important for neurotransmitter release. When you modulate calcium entry systemically, you are potentially modulating the same mechanisms that drive synaptic communication, the way your neurons talk to each other. Some studies have found associations between calcium channel blocker use and changes in cognitive performance, particularly in tasks involving attention, processing speed, and verbal memory. With Lisinopril and Losartan, the picture is even more complex and frankly more controversial. The renin-angiotensin system exists not just in the periphery, but in the brain itself. There is something called the brain RAS, and it plays a role in neuroinflammation, cerebral blood flow regulation, and even the clearance of amyloid proteins, the plaques associated with Alzheimer's disease. Some researchers have hypothesized that ARBs might actually be protective against cognitive decline. Others have raised concerns that aggressive blood pressure lowering in elderly patients, reducing brain perfusion below optimal levels, may accelerate cognitive symptoms, not prevent them. What this means for you is this. If your thinking has changed since you started your medication, that is not something to dismiss. That is something to document and discuss. And if your doctor dismisses it, you have every right to ask for a referral to a specialist who will take it seriously. The third silent side effect is one that I suspect a significant number of people watching this right now are experiencing without connecting the dots. It is sleep disruption, specifically the inability to sleep deeply, the pattern of waking up in the middle of the night, and the sense that sleep is no longer restorative. Amlodipine has a half-life of approximately 30 to 50 hours. That is an extraordinarily long half-life for a medication. What it means is that even if you take it in the morning, it is still biologically active in your system throughout the night. And because calcium channels are involved in the regulation of smooth muscle throughout the body, including in the airways, some patients experience a subtle nocturnal sensation of discomfort, chest tightness, or altered breathing patterns that disrupts sleep without them being fully aware of what is happening. With lisinopril specifically, there is a well-known side effect called a dry cough. You have probably heard of it. A persistent, irritating dry cough that occurs in somewhere between 5 and 20% of patients taking ACE inhibitors. What is less discussed is that this cough is often worse at night. It disrupts sleep. It causes microarousals, brief moments of waking that the person doesn't even fully register consciously, but which destroy the architecture of deep, restorative sleep. Many patients with lisinopril-induced cough have been told they have allergies, postnasal drip, or acid reflux. They are given antihistamines and antacids. The real cause, their blood pressure medication, is never considered or considered far too late. With Losartan, the picture is somewhat different because ARBs do not cause the ACE inhibitor cough. But Losartan has documented associations with vivid dreams and sleep disturbances in a subset of patients. Again, in the fine print. Again, rarely communicated at the point of prescribing. When you are not sleeping properly, everything else gets worse. Your fatigue deepens, your cognition suffers, your mood deteriorates. Your blood pressure, ironically, can become harder to control. The side effect feeds back on the very condition the medication is supposed to treat. And the doctor sees a patient whose blood pressure isn't optimally controlled, whose sleep is poor, who seems fatigued and a little slow, and attributes all of it to aging or to inadequate lifestyle choices. The fourth silent side effect is one that hits people where it hurts, and where they are often too embarrassed or too resigned to bring it up. Sexual dysfunction. In men, this often presents as erectile dysfunction or reduced libido. In women, it presents as decreased arousal, vaginal dryness, or loss of interest in sexual activity. And in both men and women, it is almost never brought up in the doctor's office, and almost never proactively mentioned by the physician. Let's be very clear about the mechanism. Blood pressure medications work by affecting blood flow and vascular tone throughout the body. Sexual arousal, in both men and women, is fundamentally a vascular event. Erections require robust blood flow. Female arousal involves engorgement and lubrication that depend on the same mechanisms. When you pharmacologically alter vascular tone systemically, you do not spare the genitals, you affect them. Amlodipine, interestingly, has a somewhat better profile here than some other antihypertensives, because vasodilation, in principle, should support rather than impair blood flow. But in practice, the picture is complicated by the reduction in overall systemic blood pressure, which can reduce the pressure gradient needed for full arousal. Lisinopril and Losartan, operating through the RAS system, can affect testosterone levels and androgen signaling in ways that are still being studied. What we do know is that sexual dysfunction is listed in the adverse effect profiles of all three of these drug classes. What we also know is that in survey after survey of patients on antihypertensives, sexual dysfunction is one of the leading causes of silent noncompliance, BICE, meaning people quietly stop taking their medications or start skipping doses without telling their doctors because they would rather manage their blood pressure risk than lose their sexual function. That is an extraordinarily dangerous trade-off to make in silence, and it happens because the conversation was never had. If this is happening to you, please bring it up. There are often adjustments that can be made, changes in timing, dosage, or class of medication, that significantly improve this side effect without compromising blood pressure control. The fifth silent side effect is one with serious long-term health implications, and it involves your kidneys and your electrolyte balance. Specifically, we are talking about disruptions in potassium, sodium, and magnesium levels that quietly accumulate over time and produce symptoms that doctors consistently attribute to normal aging. Lisinopril and Losartan both act on the renin-angiotensin-aldosterone system, and aldosterone is the hormone primarily responsible for regulating potassium and sodium balance in the kidneys. When you block this system, you reduce aldosterone activity. That means the kidneys retain more potassium. In most patients on standard doses, this is a manageable and expected effect. But in patients who are also taking other medications, who have borderline kidney function, who have dietary habits that affect potassium intake, or who are simply genetically predisposed to more pronounced RAS suppression, potassium levels can creep upward into a range that causes real symptoms: muscle weakness, muscle cramps, fatigue, heart palpitations, constipation, and, critically, cardiac arrhythmias. High potassium, called hyperkalemia, is not something you feel dramatically all at once. It is something that builds. Your muscles feel weaker than they should. You feel off. You feel slow. You might have some irregular heartbeats that feel like your heart is fluttering or skipping. You go to the doctor and they say, "At your age, that's pretty normal, but they haven't checked your potassium recently." Or if they have, it's in the normal range, but at the high end of normal and trending upward. Magnesium is the other critical player here that is almost universally ignored. Magnesium deficiency is one of the most underdiagnosed conditions in modern medicine. Standard blood panels do not accurately reflect cellular magnesium levels because the vast majority of the body's magnesium is stored inside cells, not in the bloodstream. When the renin-angiotensin system is disrupted by antihypertensives, the kidney's handling of magnesium can be affected. When magnesium drops, even subtly, the consequences are profound: muscle cramps, anxiety, poor sleep, irregular heartbeat, fatigue, and yes, worsening blood pressure control. The medication meant to lower blood pressure can, through magnesium depletion, make blood pressure harder to control, and nobody connects the dots. The sixth silent side effect is one that, once you understand it, fundamentally changes how you think about blood pressure management as a long-term proposition. It is called drug-induced hemodynamic dysregulation. And in plain language, what it means is this: the medication changes how your body regulates blood pressure so profoundly over time that your body loses some of its own capacity to manage it. Here is a scenario that plays out in millions of people's lives. A person starts on amlodipine. After a year or two, the doctor notes that the medication is working, but blood pressure control is slipping a bit, so they add lisinopril. Now they're on 2 medications. A year later, still not optimal. Losartan is added, or the lisinopril is replaced with Losartan. Now they're on a combination therapy. The doses creep up, the years go by. And somewhere along the way, this person notices something alarming. When they stand up too quickly, they get dizzy, lightheaded. Their vision briefly goes dark. Sometimes they nearly faint. This is called orthostatic hypotension, a drop in blood pressure upon standing, and it is both a direct effect of these medications and a sign that the body's autonomous blood pressure regulation is being overridden. The baroreflex, the body's own rapid blood pressure adjustment mechanism, can become blunted over years of pharmacological intervention. The nervous system's ability to respond dynamically to changes in position, exertion, or stress becomes compromised. And the consequence is not just dizziness, it is falls. In older adults, orthostatic hypotension is one of the leading contributors to dangerous falls. Falls that break hips, falls that lead to hospitalizations, falls that, statistically, are a major cause of accelerated mortality in people over 65. And when the doctor is told about the dizziness, what do they say? Be careful when you stand up. Take your time. Hold on to something. As if this is just a quirk of getting older, not a direct pharmacological consequence of the treatment plan they designed. The dizziness is real, the dysregulation is real, and it deserves a real response, whether that is a dose adjustment, a change in medication timing, or a comprehensive reevaluation of the entire antihypertensive regimen. Now I want to talk to you about something that sits underneath all 6 of these side effects, something that connects them. It is the concept of attribution error in medicine. When a doctor sees a patient with multiple vague complaints, fatigue, brain fog, poor sleep, sexual dysfunction, muscle weakness, dizziness, the human mind looks for a unifying explanation. And in a patient over 50 or 60 who has been on the same medications for years, the unifying explanation that the medical system reaches for, almost reflexively, is aging. Because aging explains everything. Aging is a catch-all that requires no investigation, no adjustment, no accountability. But aging does not explain the temporal relationship between starting a medication and experiencing a new symptom. Aging does not explain why some of these symptoms improve dramatically when a medication is switched or a dose is reduced. Aging does not explain the mechanisms documented in the pharmacological literature that directly link these drug classes to these exact experiences. You are not imagining it. You are not being dramatic. You are not just getting old. So, what do you do with this information? This is the most important part of this conversation, and I want you to listen carefully. The first thing you do is document. Start a journal if you haven't already. Write down when symptoms started or worsened. Note the relationship to when medications were initiated or doses were changed. This is not hypochondria. This is being an informed, active participant in your own care. When you walk into a doctor's office with documented observations over time, you are impossible to dismiss. The second thing you do is ask specific questions, not, could my medication be causing this? Because that question is easy to deflect. Instead ask, has the link between this medication class and this specific symptom been documented in clinical literature? Ask your doctor to check your electrolytes, specifically potassium and magnesium, and not just whether they are normal, but where they fall within the range and whether they've changed over time. Ask about your kidney function, because both Lisinopril and Losartan are metabolized renally and have implications for long-term kidney health that need monitoring. Ask about orthostatic blood pressure, meaning they measure your blood pressure lying down and then standing up, because the gap between those numbers tells a story that sitting blood pressure alone cannot tell. The third thing you do is explore alternatives if appropriate. There are multiple drug classes used to treat high blood pressure: calcium channel blockers, ACE inhibitors, and ARBs are not the only options. Depending on your specific cardiovascular profile, your kidney function, your concurrent conditions, and your experience of side effects, a different medication or a different combination might achieve the same blood pressure control with a completely different side effect profile. That is a conversation worth having, not as confrontation, but as collaboration. The fourth thing you do is address lifestyle aggressively and in parallel. I know that sounds like something you've heard before, and I know it can feel dismissive when someone mentions diet and exercise while you're dealing with fatigue so profound you can barely get off the couch. But here is the specific reason it matters in this context. Certain lifestyle interventions have been shown to reduce the required medication dose for blood pressure control. The DASH diet, regular aerobic exercise, sodium reduction, alcohol reduction, magnesium-rich foods, stress management, these are not platitudes. They are tools that, in combination with medication, can sometimes allow for dose reductions that meaningfully reduce side effect burden. You are not taking medication instead of lifestyle changes. You are doing both, and you are doing both strategically. The fifth and most important thing, and I mean this with every ounce of sincerity I can communicate, do not stop your medication without talking to your doctor. Please. Abrupt discontinuation of antihypertensives, particularly after long-term use, can cause rebound hypertension, a dangerous spike in blood pressure that can precipitate a stroke or heart attack. The risks of uncontrolled high blood pressure are not theoretical. They are real, they are serious, and they are the reason these medications exist. The goal of this entire conversation is not to scare you away from treatment. The goal is to make you a better, more informed, more empowered patient who can have real conversations about real symptoms and real solutions. There is something deeply wrong with a healthcare system in which millions of people are silently suffering side effects that have been dismissed as the inevitable toll of time, when those side effects have documented pharmacological explanations and, in many cases, manageable solutions. There is something deeply wrong when patients quietly stop taking life-saving medications because they feel unheard, because the quality of life they've been left with doesn't feel like living, because nobody ever told them that what they were experiencing was connected to the pill they take every morning. You deserve better than that. You deserve a physician who looks at your fatigue and asks when it started and what else changed around that time. You deserve a physician who, when you mention brain fog, reaches for your medication list before reaching for a referral to neurology. You deserve a physician who acknowledges that the body you are living in is complex, that the medications we use to treat one system affect other systems, and that the experience of being a patient on long-term medication is not a background condition. It is a dynamic, evolving reality that requires ongoing attention. The 6 side effects we talked about today, the exhaustion that doesn't lift, the cognitive fog that dims your sharpness, the sleep that doesn't restore you, the sexual function that has quietly faded, the electrolyte imbalances that sap your strength and threaten your heart rhythm, and the blood pressure dysregulation that makes you dizzy and puts you at risk of falling. These are not the price you must pay for having high blood pressure. They are signals. They are your body talking to you. And you have every right to make sure someone is listening. Take this information, take it seriously, talk to your doctor. If your doctor doesn't listen, find one who will. Advocate for yourself with evidence, with documentation, with the understanding that being your own best health advocate is not optional, it is essential. Your blood pressure needs to be controlled, and you need to actually live your life while it's happening. Both of those things are true. Both of those things are possible. And the first step toward making both of them happen is exactly what you did today. You started asking the right questions.